Good afternoon. Hello, and thank you for joining the Pituitary Network Association's webinar program. The PNA is a nonprofit organization that relies on the support of our members and donors. We offer this webinar series to help educate patients, their families, and their healthcare providers. During the webinar, feel free to type in your questions at any time. Please note that all questions will be saved until the end of the webinar. We have allotted time to answer as many questions as possible. Any questions that are not answered will be reserved and answered by email. Our webinar today is the Hypothalamic Pituitary Dysfunction in young athletes with head injury, presented by Dr. Saad Sakal. Dr. Sakal is the director of the Metabolic Care Center in Mason, Ohio, a center for excellence in diabetes, metabolism, and endocrinology. They heal the spirit, mind, and body. American Board Certified Endocrinology, Diabetes and Metabolism, Geriatrics, and Internal Medicine. After his fellowship at George Washington University Medical Center and the NIH, Dr. Sakal has more than 30 years of clinical research experience in the field with extensive national meetings presentations. His recent interest is starting research of traumatic hypothalamic injury in athletes, including football players. Dr. Sakal and Professor A.M. Albasser developed breakthrough technologies for maintaining optimal diabetes control, including patented software algorithms that target blood glucose control through a closed-loop system that mimic hypothalamic balance system with stress feature. He is an emeritus assistant clinical professor of medicine, Northeast Ohio University's College of Medicine at Rootstown, Ohio. Thank you, Dr. Sakal, and welcome.
Thank you. This is a really nice introduction, and you really made me feel good just to start. The hypothalamic dysfunction in young athlete is a very important subject, and I hope you have my desktop clear to everyone by now. Is it?
We're working on it. Oh, here we go. There we go. There we go. Okay, you're up. Go ahead, Dr. Sakal.
All right, so the subject is a very intriguing subject, and I know very often in pituitary diseases we focus on anatomy as well as the influence of hormones on the rest of the body. But in this presentation, I want to focus more on functional changes. And as I have been introduced, when it says emeritus assistant professor, it means half retired. So I had more time now to look at a lot of what I have missed in the past and what I have learned from my patient. This is a learning journey that I hope you will go through it with me. And we will proceed from what we know to what we don't know, what we really need to know or should know. Here's the background of this. We presented this as an abstract at the Endocrine Society meeting in Chicago earlier this year in June. And this was a combined session with the International Congress of Endocrinology. My son and I have looked at a number of patients who presented with hypothalamic features after injury, and those were young athletes. And as you know, the recent medical and public literature have really given an immense emphasis on the traumatic brain injury. That is what affects the brain from trauma. And you have heard about its impact in young football player with its related executive neurologic manifestations and features. Some of them are severe enough to cause significant disability when they're about 40, 45, or 50 years of age. And as you also know, there has been recent settlement close to 700 million or slightly more in dollars to compensate those athletes for what has happened to their brain during their professional life. Interestingly, I'm happy to say 100 million of it will be devoted to research on the subject, so we should learn more in the next few years than what we have known in the last 10 years. Now, this is a quote from a very recent magazine published by the Endocrine Society called Endocrine News. And this is from the October issue, just received it in the mail a few days ago. As we planned for the symposium, the seminar, they asked someone from Chicago, a freelancer scientific writer, to look at the same subject and write an essay. And if you could see the slide, you would read with me at a glance the whole summary of this essay. It says each year in the United States, about 2.5 million children and adults suffer a traumatic brain injury. And depending on the injury, problems that can occur include growth issues, fatigue, weight gain, low blood pressure, low libido, loss of muscle mass, and amenorrhea in the female. Healthcare providers who first treat traumatic brain injury are often unaware of potential long-term effect. Very concise statement, and if someone is busy and you don't want to hear any more, you could leave right now, because this is really the state of this issue today. My purpose, though, is to focus more on how we miss it, why do we have to look at it, and what can we do. Now, it goes further in this article, and it says recent headline of this disabling head injury to returning Iraq and Afghanistan war veterans, as well as recurring concussion to professional athletes, have placed the incidence of traumatic brain injury front and center in the mainstream medical news. However, it has been long the leading cause of death and disability in the USA, and what happened to the body hormones following these injuries have become an increasingly significant public health concern, and this is our focus today. This is an image just to bring us to the idea of what happened during these traumatic injury or the so-called concussion. Sometimes it's also named mild brain injuries, traumatic brain injuries, or athletic brain injury. I put the cursor here on the center of the image where it says the rotational force centered on the midbrain and the thalamus hypothalamus area is really the main axis where all forces actually meet. Think about it. Again, the cursor shows you how an angular deceleration when someone is hit against fixed object make the whole brain move forward except right at the pituitary hypothalamic midbrain section. And you know, you could imagine right there what happened to these fragile cells. It always puzzles me that no one had looked at it before. Well, where did that come from? Where am I saying no one is looking at it? Well, let me show you. Here is the International Classification of Disease, the most recent edition that's been published this year and will be applied next year to all physician and institutional procedure billing. And it has this description of the post-concussion syndrome. As you could see, they speak about a lot of time and symptoms of non-specific nature. Here they are: headache, dizziness, fatigue, noise intolerance, irritability, depression, anxiety, emotional lability, subjective concentration, memory, intellectual difficulty, without neuropsychological evidence of marked impairment. They also speak about insomnia, reduced alcohol tolerance, meaning they become very intolerant to alcohol, as well as a preoccupation with these above symptoms and fear of brain damage to the point a person become or described as hypochondriac in concern and adopt a sick role. And just looking at this, tell me, where do you see the hypothalamic pituitary hormonal axis presented in this description? Nothing. As a matter of fact, what disturbs me most about this classification or definition, that they're calling them hypochondriac or adopting sick role. And I'll tell you, as you could see in the next few slides, those are really sick people, not adopting sick role. So here's the guideline for treating these sport injuries. And I don't want to go through this whole thing, but I would tell you all of it speaks about how do you remove the injured person from the scene, how do you take care of the neck, how do you take care of the neurologic exam, and when do you bring them back again. Nothing again about hormone or functional disability, which I hope to describe to you. So this midbrain area contains the hypothalamus, contains the pituitary, and the pituitary stalk in between. So what is the hypothalamus? Let's speak a bit more about what we know. We know the hypothalamus is the master control for hormonal balance throughout the body by its influence on the pituitary hormone system. So that's the first function. The second function, in addition, its nuclei control metabolic processes and function throughout the body by coordinating many nuclei in the central nervous system. We call those central cortical nuclei, in the midbrain, in the thalamus, in the limbic system, which you all know relate to mood and anxiety and depression issues, as well as a full arrays of neuroendocrine pathways otherwise. All of this affect most vital functions of the human body, of all of us. This is the typical textbook description of what hypothalamic hormone names are, what do they do to stimulate or inhibit part of the pituitary function, and the pituitary hormone that is affected. So for example, you know, corticotropin releasing hormone is stimulating hormone to the corticotropin, which goes ahead and stimulate the secretion of cortisol from the adrenal gland as well as adrenal and androgen. Most of these hypothalamic hormones are stimulatory except for dopamine, which is an inhibitory prolactin factor and inhibit prolactin production from the pituitary. And as you know, when this is diseased, very often prolactin increases and causes problem with hyperprolactinemia as well as amenorrhea or disturbance in menstruation, as you may know. The other inhibitory hormone is somatostatin, which slows down growth hormone production and balances the excess growth hormone in the body. Otherwise, every single pituitary hormone has a hypothalamic hormone to stimulate and coordinate its function. And there are loops. You've heard about loops, how the hypothalamus produces from the pituitary hormone that goes, for example, to the adrenal, and how the cortisol goes back in a feedback loop to suppress its own excess or production. But we're not going to spend too much time on this today. Briefly speaking again, we have the hypothalamic system inducing by either direct effect on the posterior pituitary and ADH and oxytocin that influences the uterine contraction or the contraction of the mammary gland muscle, and the vasopressin or ADH, as you know, control the blood pressure and water excretion. This is all from the posterior pituitary. From the anterior pituitary, on the other hand, the pituitary hormone stimulate the TSH for the thyroid, the ACTH for the adrenal, and as you know, FSH, LH for the gonads, being ovaries in the female and testicle in the male. So this is the hormonal function. Let's go next and learn a little bit more about this coordinated system. Again, the pituitary is affected by the hypothalamus, and here's the hypothalamic nuclei we just alluded to. There are many of them. Each one of them has a name, has a function, and correlate with pituitary hormone. One of them here is called suprachiasmatic nucleus, is responsible about sleep and awakening. Some of them are responsible about receiving input from olfactory sensory perception in the nose and the mouth, as well as from the retina and the eyes, and coordinate all of that with other physiologic function in the body. And we'll talk slowly about this more to explain it further, so when we look for disease entity, we know what it really does. Again, I just could not believe over the years that any head trauma and concussion, and there are 2.5 million of them every year, that influences in its major impact this central command system that doesn't affect its function. And look at how delicate this hypothalamic cells are. They are actually neurons, like a nerve cell, and it has a central body as well as many small little radiated reticular formation from it that connects all over the brain. Look how well it connects. It connects to the cerebral cortex, it's correct to prefrontal area, it corrects to the reddish hue, this colored area that's limbic system, responsible about mood, and then this bluish area that's called the thalamus, that's responsible about pain, balance, concentration, and a variety of other functions as well. So what are these vital functions then that gets controlled by the hypothalamic neural cell? Although they're neural in formation, they produce so many hormones that they are considered the master endocrine system. Along with the pituitary, they both coordinate everything in the body. So let's leave the hormone for a second. You're all familiar with it. And let's speak about the other non-hormonal function, although some hormones also contribute to these functions. Energy. Everything that relates to energy, fatigue, tiredness, lack of energy, increased energy, is controlled by energy stat, by the dynamo in the hypothalamic cell. In this fashion, it also controls what macronutrient we want to eat for energy. Carbohydrate when we miss it, protein when we have too much carbohydrate, and fat to store for the future. It also controls temperature. We have a temperature controlling cells called the thermostat of the body. And as you know, we all have a temperature of 98.6 normally, plus minus 0.2, very, very small little variation in general. However, some people may have disturbed hypothalamic cell function, and they may end up with a very low temperature, and they feel cold all the time, or very high temperature. They feel hot all the time, and you've seen this and you've known about this in pituitary diseases, thyroid diseases, adrenal disorders, and even hot flashes that happen after menopause from ovarian hormone function changes. The third component is appetite and weight. They're interrelated, as you know often. If we have too much appetite and hyperphagia or craving, we do get more to eat and we end up with higher weight. If, on the other hand, our appetite system is lower in its set point, we end up having not a high appetite in general, and we end up eating less and weighing less, and those are the lucky one between us. They're few, but they do exist. They burn everything quick, and they say, you know, I have a high metabolism, slow metabolism, or low metabolism. And for years, doctors and providers used to laugh at patients and say, no, it can't be true. I mean, we all have the same metabolism, but the truth is we don't. My patients were right. They have either slow or high or normal metabolism, again controlled by the hypothalamic cell system. It also controls sleep, so some people have insomnia or excessive sleep. It controls diurnal rhythm and vice versa. Diurnal rhythm is influenced by the retinal light and dark cycle, as you know, affect many vital function. It wakes up the body. It's called the arousal state, and that what get disturbed in many pituitary disorders as well. It also correlates its activity with the limbic system, controlling the mood or the feeling of well-being. How often did you hear people say, I just don't feel well? And they can't describe it any further. This is where it is. Reproduction, libido, erectile dysfunction in the male, or lack of libido in the female are all, again, coordinated in the hypothalamic gland area. And then again, let's look at pain and muscle tone and muscle spasm, which is correlated with thalamic nuclei, which is next to the hypothalamus. As you could tell, the name hypothalamus says simply it is the area under the thalamus, and that's why it's called hypothalamus. But the correlation and the coordination between the two is very important for fibromyalgia, chronic fatigue, and pain syndrome in general. And finally, the hypothalamus coordinates a lot of its activity with the sympathetic, parasympathetic systems. Those are mediated through nerves that passes through the body all over and control GI, GU, vascular, tone, and a variety of other function, all the way from salivary gland and excess salivation to the bladder with irritable bladder function. Here are some of these nuclei. I don't want to think that I could either memorize them or anyone will. I just want you to look at the lower part of the slide where you see how many influences affecting the hypothalamic nuclei from the vagus, the viscera, from the adipose tissue and fat cells, from the pancreas that relate to insulin and amylin and diabetes incidence, the muscle, as well as the hormone that we've talked about, the circadian input and the retina and olfactory system. All of these comes into the hypothalamus nuclei in the center of the image that we're talking about, and then come out with order to the pituitary gland, as you see here on top, controlling the endocrine system, as well as cerebral cortex, limbic system, cognitive function, concentration, social interaction, reward, and body fat, brown or white fat, which is also becoming very important recently. Here are the fibers that are spreading again throughout the body. So all this interest in the traumatic brain injury, still very careful screen of the literature, and I've done this a number of times now, including half an hour ago, just to be sure I haven't missed anything today or yesterday. It all failed to document any specific reference to the hypothalamic dysfunction as an entity, although it's a very vulnerable, delicate system which may be associated with these injuries. So we looked and we presented the gonadal function data on 10 consecutive young patients who have been referred for fatigue or suspected gonadal problem. So we searched for a traumatic hypothalamic injury syndrome, and most of these were very young, 20s, 19, 18, 8 of them at least. 2 were less than 36 years old. 1 was 32 and 1 was 36. So these are very young people. Here's one example, just to show briefly how bad it could be. JM is a 19 years old male who came in because of extreme fatigue and a clear decrease in libido. He was recruited to our local college on a sports scholarship to play football because of his high school performance. He was complaining when he came in the first day, "Oh, I just can't do anything, doctor. My coach wants me to do exercise, training, and I can't do it. My scholarship now is in jeopardy. My future is at risk, and I don't know what to do." Now, he had head injury, and it took a while for him to remember the detail, but he said, yes, it was associated with loss of consciousness. I was in senior high school when they recruited me, and I really have lost consciousness for a few minutes before they took me to the hospital and checked me out, and they say everything was fine. On his physical exam, he looked tall, he's athletic, he's a big man, soft muscle. I mean, I expected his muscle to be as tough as they could be for his training and for his description, but they were very soft. He had severely depressed mood, and we do this on a Zunk depression scale usually, and he had apparent surprising muscle weakness as well, despite his big size. His testosterone was 4, and the normal is anywhere from 5 to 30. His FSH was about 3.4, and LH was 4.2. And as you know, when testosterone decreases, the normal feedback of the pituitary and the hypothalamic cell raises the FSH massively, but it was not raised in him. We did on him a growth hormone after L-DOPA exercise combination, and it was 3.8, which is really borderline inadequate response, and his prolactin was 16. And in our laboratory, I am always suspicious any prolactin above 14 or 15 is abnormal. But this is not very abnormal, it's mildly abnormal. I could tell you the rest of his hormone level were generally okay, but after treatment he felt better. So this was one example, and let's look at the rest. We prospectively tabulated the head injury data and all the symptoms in these young patients who were referred to us again for hypogonadism and fatigue. And when we have looked at the age again, as I said, there were 3 of them below the age of 20, 5 of them below 30, and 1 was 32 and 1 36. Again, very young group, where they were screened for all the symptoms, prior head injury, testosterone, and other hormone of the pituitary, as well as vitamin D, because we have a special interest these days in the function of vitamin D in many people who complain of general fatigue. We also looked at other metabolic disorder if they have something suggestive in the clinical history, like evidence of diabetes, parathyroid gland, and so on and so forth. So how did we do the history screen for these young men? Well, their screen was very easy from the review of symptoms, which is a sheet that's taken from the common office intake sheet that we do today for electronic medical record. This is a sheet that has all the symptoms, and a patient only needs to check what he has, positive or negative. So it was very easy to look at those sheets and determine the symptom they were complaining of. They were tabulated also for specifically the hypothalamic symptoms that we just alluded to: the energy, the temperature, the weight, the sleep, the mood, libido, sympathetic, parasympathetic balance issues as it presents itself in GI, GU symptoms mainly. We also looked at the memory, concentration, and other cognitive function. And I'm repeating some of these symptoms because I know you all have experienced some of them at one time or another. And we as provider have not looked at the whole symptom constellation together to realize they were all actually coming from hypothalamic control system. So what criteria for diagnosis of any disease we've used? Well, hypothalamic dysfunction is diagnosed when 4 or more systems combination are involved. So if someone had 4 systems of what we have described or more, he or she had hypothalamic dysfunction. Hypogonadism is defined in the literature as, by a clinical syndrome with low testosterone, and it could be primary from the testicle with high FSH, or it could be central from the pituitary hypothalamic area with normal FSH, LH, or low FSH, LH. And finally, vitamin D deficiency is defined as symptoms associated with level below 30 nanogram per deciliter. So how often we found those hypothalamic symptoms in these 10 young men? Let's look at energy, fatigue, tiredness. They were in 9 out of 10, 90%. Temperature problem, either too hot, too cold, chilled, or cold extremity with hot centrum, or vice versa, or hot flashes, or sweating, 70%. Appetite, weight changes, which most often gain of the weight, 70%. And let's look at the pain and muscle spasm, fibromyalgia syndrome, almost 80%. Mood disorder, anxiety, depression, mood disturbance, dysthymia, irritability, post-traumatic stress syndrome, even in some of them, 80%. Libido, erectile dysfunction, reproduction problem, 80%. Sympathetic, parasympathetic symptoms in the GI or GU symptom, from constipation to diarrhea to bladder irritation to urgency to irritable bladder, almost 90%. All of them, of course, had injury. That's why we have put them in the series. In summary, here's the hypothalamic symptom we noticed in these young men. 100% of them had injury. 90% have either hypogonadism or fatigue or loss of sympathetic, parasympathetic, visceral imbalance. And 80% had mood disorder, pain, muscle spasm, fibrositis, fibromyalgia syndrome. And 70% have temperature dysregulation, appetite, weight changes, and sleep problem. The objective point, we always look for it because we don't want to depend only on symptoms or complaint. And those are called the fibromyalgia trigger point. Their point where when you touch them, they trigger pain. And there are positive point and negative point. And guess what? In these 10 individuals, we were able to document it in 8 of 10, 80%. And they have a lot of painful trigger points. 17 out of 18 was the average, and some of them were as low as 14, but some of them even have 20 points, which is higher than what has been described in the literature. By the way, anything above 11 is positive for the diagnosis of fibromyalgia. So they really have a lot of fibromyalgia. We also said that the hypothalamic dysfunction is when you have 4 or more systems. When you have 4 or more systems, we call this definite hypothalamic dysfunction, and this was evident in 9 out of 10. However, it could be likely disease if there are 3 systems or less, and this was only in 1 of them. Here's the laboratory data. We will present only hypogonadal and vitamin D data since the space doesn't allow, the time doesn't allow, but I could tell you most pituitary hormone were basically in the normal range. So let's look at the testosterone. They have low testosterone, which was found in 9 of them, since the group were often referred for this purpose or the suspected diagnosis. The average free testosterone was 5.9, the normal being, as you know, 3.4 in these people was 3.4 to 6.9, and the normal is 5.5 to 30. So really, most of them were much below any lower level you could think of. And let's look at the LH. You would expect the LH to be very elevated, but it was non-elevated in 7 with an average number of 4. And the FSH was also around 4. So it's between 4 to 5. And the range, as you know, for normal is 3.2 to 5.2. And if the testosterone was low, they should be above 10 or 20 or even 30, as we see sometimes in people who had complete primary insufficiency. Prolactin was not too helpful. Some of them were abnormal above 15, and some of them were normal. But interestingly, the PSA was always low and very, very low, below 1 nanogram per deciliter in 8 of them. The normal being 1 to 4. So really, this is an intriguing feature of obviously the lack of testosterone or dihydrotestosterone effect. The average was 0.7 and the range was 0.2 to 1.2. I don't want to bore you with too many numbers, but for vitamin D deficiency, we found it in 7 out of 10. The average was 24, and we said the normal is anything above 30. So that was a very significant item to us as well, and surprising. So summary of the study, the hypothalamic dysfunction is most common disease in these football or athletic player with this triad, with the 3 symptoms or combination: prior head injury, hypogonadism, and fatigue. When you have these 3 together, more than 90% have hypothalamic dysfunction. This obviously exceeds any possible percentage of any disorder like traumatic brain injury, although it could precede it or sometimes associated with it. It is unfortunately often forgotten. Of interest, as we said, 70% has also low vitamin D and a very low PSA, and I still don't know what to do with these information, but it's something for the future to begin to look at and to see if there is a relationship between vitamin D and hypothalamic dysfunction in general. So what do we think is needed? Well, we think a large prospective study for young athletes is needed. We should be probably screening them for all 7 hypothalamic system as a mandatory effort, which is non-invasive, only simple questionnaire. And we probably should get baseline hormone and vitamin D. And as for the dynamic pituitary hypothalamic testing, it probably should be only done if the baseline were suspect, the baseline data were suspect. This is a controversial area today in the literature. Some people have just published 2 months ago a paper from Spain for 36 young children saying it is not that useful to do the dynamic testing for every concussion. However, my own feeling is I think if you follow them long enough, you probably would be wiser rather than leaving them alone. And I'm prepared to leave the dynamic testing for suspect cases rather than all cases. At any rate, I still think that we should repeat those levels after any traumatic head injury, or if we miss them, maybe once a year to figure out who developed these problems and who does not. When this should be started? Well, I think as soon as there is a rough contact sport started for any individual, we should be aware of this possibility and begin to follow it. If it starts in middle or high school, that's when we should do it. If it starts in college, definitely we should do it as well. If proven any time that an individual had, during the follow-up, a hypothalamic dysfunction, I think we should stop the exposure to head injury immediately. Don't you think? I think that's what really makes sense. And a lot of people sometimes tell me, well, who cares? You know, they don't have neurologic disease, they don't have paralysis. Well, I think we should care. We should all care because they are our young, they are our children, and they are the next generation, and we can't just ignore it. This is, by the way, not only my opinion. The piece I just mentioned to you, published in Endocrine News, have also the same question: when to screen and when to treat. And they're speaking about the fact that this diagnosis is often missed. And here's what Dr. Gandhi from Johns Hopkins says. He says emergency room staff and primary care doctors are the one who are seeing these kids come in with head injury, and they're thinking concussion and all that old school stuff. Concussion causing headaches, maybe some dizziness, vomiting, says Gary Wand. They are thinking the kids are going to get better, and they're just not aware that you could have these hormonal changes. Now, he says he sees 4 or 5 cases a year at Johns Hopkins of that nature. Now, why we should be looking early, not late, not wait until they really are sick? Well, head injuries are very common in children. It's in the vast majority lead to endocrine dysfunction, as a review mentioned or published in February of this year by Rogel says. He said in one of the larger studies that he looked at, 1,000 traumatic brain injury patients collected from the literature, there was a prevalence of some form of hypopituitarism, meaning hormonal dysfunction, in 27%. So here's what I'm saying. I'm saying hypothalamic dysfunction exists in at least 80 to 90%. And hypopituitarism, which is the next stage, comes in about 27.5%. I don't think that should be ignored. So, any speculation, any theory connect these information together? Well, my own feeling, and I wouldn't speculate in general in medicine about anything, but since we're chatting and conversing about this, and we will be having question and answer, here's a question that I get often asked. Do you think there is a relationship between these stages of disease? And I think what happened is this: head injury in childhood or youth leads early to hypothalamic dysfunction frequently, which is probably should be recognized in the teens or 20s, as we have described in this series of patients. In a few years afterward, in their early adulthood, I think they develop pituitary dysfunction, and the result begin to show up in their 30s, and that's where most of us begin to be aware of the issue. However, much later in their 40s, the traumatic brain injury syndrome that has been described as a form of degenerative disease with possible autoimmune process seems to appear, and by then, very often it's reversible and close to death. My conclusion: common sense invites us to look at the issue much earlier. Could we still have a reversible condition, or preventable, or at least treatable? And when would that be? I'd say now. Here's some references for some of you who are interested in pursuing this further. And the most recent references have been just published this year, 1, 2, 3. And here's the last one in October 2014, just a few days ago. Thank you for your listening. I truly appreciate the invitation. I hope I have led to some curiosity as much as I have this curious feeling about this condition, and I'm happy to answer any question you might have. Thank you.
Oh, thank you, Dr. Sakal. That was very fascinating, very interesting. We do have just a couple of questions. I think it was very thorough. First question: what is brown or white fat? You mentioned that earlier in the presentation.
The brown fat is an intriguing newer discovery that says not all fat tissues are idle and do nothing but store fat. They're really in between muscle and white adipose tissue. So if the white adipose tissues were mainly storage and really causes the obesity that we all get concerned about, the muscle are the activity cells and the brown adipose tissue are in between. They could turn to muscle in time. Some people think they may present a stem cell or multipotential cell that, if energized enough by exercise and a variety of other factors, it may turn out to be a brown, muscular, high energy burning tissue, while if it's led to be overfed and overwhelmed by excessive meal and hyperphagia, it may turn to white adipose tissue and add to the obesity. So that's the intriguing part about it. And there's a lot of excitement to see how can a brown fat could be moved into more energetic level, and if even white adipose tissue could be converted into brown fat.
Wow, that's very interesting. Okay, next question. How do you treat these young men with hypogonadism? Hormone replacement therapy? Question mark.
Definitely. As we treat most hormonal deficiencies, we treat with replacement therapy just because we haven't had the art, obviously, good enough to get stem cell to produce pituitary cell and do the job, or hypothalamic cell yet. And the replacement therapy depends again on the major deficiency. If someone has hypogonadism, we treat with testosterone for the young men. If someone has idiopathic primary ovarian failure, which is seen in a very active marathon runner female athlete, we lead to proceed with both replacement therapy as well as maintenance of an appropriate optimal body weight. If someone had adrenal insufficiency, which is the most dangerous level, which only appears late in the disease, then they need obviously cortisone. And if they do have some difficulty with thyroid dysfunction, we will give them T4 L-troxin preparation. Now, for the non-hormonal component, we look at the main issues that bother the individual, and we have to deal with it as well. Luckily, in our young men, for example, only testosterone therapy was adequate to correct all of his symptoms. However, some individual may have had enough influence on the limbic system. They may need a treatment as well for depression by either cognitive therapy or a variety of therapy, including medication, and some for the issues related to gastrointestinal or GU symptoms may need some mild symptoms therapy until they return to normal. So again, medicine doesn't have a lot of treatment except replacement and improving symptoms and improving the style or quality of life. As for the drastic primary therapy to correct these problems, we really have to wait until we have some more advances in both genetics and stem cell technology.
Okay. The next question is, what would treatment be if tests deemed positive for hypothalamic condition?
What test?
Oh, what treatment? Treatment.
I missed this part. Oh, the treatment again, I described it. People who have energy difficulty, we work mainly on improving their energy, and there are some medicine that would help with that. Mood problem, we treat the mood problem with either antidepressant or anti-anxiety. People who had evidence of weight problem, we use a variety of issues to treat weight. And as you know, this is a $100 billion industry today as you deal with the weight, from diet to exercise to medications, and there are a number of medicines that are reasonably successful. The treatment of hypothalamic dysfunction is very, very promising and very gratifying to both the patients and the physician.
That's really neat to hear. Okay, the next question. My daughter, 24, has high cortisol, high prolactin, 17, testosterone, but nearly non-existent female hormones while on birth control, head injury at age 18 months, amenorrhea, even on pill. What do you recommend?
Wow.
Yeah.
She got it. I'm glad she, has really collected all of these observations. Those are very, very good observations. Those are not easy ones to treat. The what they call the primary amenorrhea girls are really a challenge to most of us. However, there are some specialized center that uses what they call GnRH infusion therapy, trying to mimic the normal pattern of hypothalamic burst of the GnRH, which is the hormone that control FSH and LH. And there has been some successful cases with some of these girls. It's not an easy thing. I feel, really so compassionate to the mother who had this type of situation, but infusion therapy with GnRH seems to be the at least available mode right now of treatment. Birth control pills, I might add, is not a treatment, but only a symptomatic therapy to produce a cycle if the girls had enough, obviously, development to get the cycle. So I hope at least this component is treated.
Okay, wonderful. Next question. Dear Dr. Sakal, what are your thoughts on isohormonal therapy? Early texts for interruption of organ damage, autoimmune, question mark.
The question has been, frequently raised recently in the internet literature. And I say internet literature because unfortunately, scientific literature and the NIH have not really looked at it very carefully, although the NIH have decided, because it's frequent issue that comes up all the time, that they really need to do a study like this. So they have started a comparative study about the comparison between hormone, or sometimes we call those compounded hormone, or variety of other ingredients to see how it fits. And I think with my own gut feeling that yes, there is a sort of benefit from using some of them. The question though, where is the benefit? Which one is the right one? We just don't have a very solid evidence. So when people tell me I've tried it and it really works for me, I tell them keep it. When some people tell me no, I tried it and I don't seem to, get any result, I say it's about time to stop it based on the expense, because they're usually more expensive than the so-called traditional therapies. As you know, some of them are coming from plant bases. Some of them are considered only inducer for natural hormones. And again, the jury is out right now on making a decision. And all what I could say to an individual who's interested in that arena is give it a try, as long as the expense is not too high. And if you do get the benefit, keep with it. If you don't, it's time to stop.
Okay, wonderful. Next question. Do you know of or have data on GnRH levels after concussion?
That's a very good question, and that's really what I like to see done. I mean, when I said we need a large prospective study, studies often take a lot of both time, energy, and money. And my sort of vision for the study is to begin at the middle school and keep it for 6 years until people graduate from high school and do it on a yearly basis. And if we're lucky, we could follow with them also in college if they don't move far away. But this is the study that needs to be done. GnRH after concussion and or traumatic injury, the data are almost nil. So that's where we have to begin to look at. And this is called dynamic test. And I alluded to the fact dynamic tests are now controversial because of their expense. Just because they're invasive, you have to get a number of blood samples, at least maybe 4 to 6, and it does take time, energy, and money. So some people are arguing we shouldn't do it for everybody, and I agree with that. But again, on the other hand, if I see someone who's really highly suspect, a girl who's having some problem with her period, a young man who's really having difficulty with energy and fatigue, I would like to do those tests for them and see if there is any change. But I'm only one voice in this, and I'm hoping that you all add voices to this mysterious illness that is the most common disease that is forgotten in the hype of both the NFL situation as well as the emphasis of the medical community on getting hard data and hard evidence proven by pathology and histology and anatomy, which sometimes could be very late.
Okay, wonderful. Now,
Did
you
I
mentioned...
explain it well, or they're still not too clear? I mean, my
Oh,
answer
no,
is not enough for the person.
I think you did, and I've not gotten any further questions from that person, so I think so.
Okay, good.
Okay, and then you had mentioned PSA. What is it in regards to? What is that?
Well, you know, PSA is prostatic acid phosphatase, which is the test used in men to tell about prostate function.
Okay, that's what we thought.
Any individual who has, normally it's 1 to 4, but any individual who has higher level, we get to worry about prostatic hyperplasia and even cancer incidence. So it's used as a screening for cancer in men.
Okay. And
very often when someone gets testosterone therapy, we watch it because we don't want to stimulate a hidden cancer or miss something that is silent. So my observation in those individuals, although they're young and it should be between 1 to 4, it was often below that level, telling us that they really have no influence of testosterone on any cell in the body, and that is only a criteria to look at the testosterone function. But you know what testosterone also does in young men? The muscle buildup, the bone maintenance, the female even depend on testosterone to some bone activity. It also helps the skin, the hair. It's a building hormone. So when nothing is affected by testosterone, that means catabolism is spreading in the body. That is destruction of all lean body tissues.
okay.
And that's why the treatment is important. It's not for sexual function. That's the last item that people complain about, interestingly enough. Although it's important, but the main thing is anabolism, building the body, depend fully on a maintenance of normal hormonal milieu.
Okay. Okay, wonderful. Okay, what does the dynamic testing consist of?
Dynamic testing in pituitary hypothalamic disease are what we call insulin tolerance test. Many people heard about that, where we give insulin to stimulate hypoglycemia and stimulate the growth hormone, cortisol, and epinephrine response. It's also used with TRH, the so-called thyroxine-releasing hormone, in testing the thyroid system. It's also the GnRH that the earlier individual asked about it, where it stimulates FSH-LH and tells us about the integrity of the hypothalamic pituitary gonadal function. And those are some of the dynamic testing we use for the pituitary gland. Now, growth hormone has a little bit more variety of those tests, including L-DOPA that I just mentioned earlier, exercise, the insulin tolerance test, as well as priming sometimes with estrogen.
Okay, wonderful, wonderful. I have time, I think, for one more question. I just, Okay, this one last one. How do you feel about baseline hormonal testing for all annual physicals across the board?
That's a good question. And you know what? Insurance company are going to really go banana if that is being requested. It costs a lot of money. We always look in medicine of what we call benefit expense ratio or benefit cost benefit ratio. And it's not proven that doing hormone testing every year as a part of the yearly physical is that helpful. I think we do less than what need to be, and I don't think we should do it all the time. One that has been shown to be very cost benefit efficient is the TSH for thyroid disease. It's not very expensive, it's easy to do, and it really does give a hint about the thyroid pituitary integrity. And if that is abnormal, then I think we're entitled to proceed with further testing. If that is normal, I think it's adequate not to proceed any further.
Okay, wonderful. Absolutely fascinating presentation. And we thank you, Dr. Sakal, so much. And this concludes our webinar presentation. If we did not get a chance to answer your question, we will be answering them via email. The PNA wishes to thank you for participating in our webinar program. There will be a brief survey after the webinar. Please fill it out to help us provide you with the information you need. We invite you to log on to www.pituitary.com or visit our bookstore. We have books at pituitarybooks.com. Oh, I'm sorry. It's www.pituitary.org. Sorry about that. And we wish you a happy afternoon. Thank you, everyone.
Thank you.
Thank you.